Alrighty, I think that is our cue. So good afternoon, everyone. Thanks so much for coming to the colloquium this afternoon. It's my pleasure to introduce a friend and colleague of mine, Dr. Abby Wilson from the University College London, UCL. She's currently a research fellow at UCL, but prior to that, she did her PhD work at the University of Loughborough, where she focused on corneal biomechanics. She then took a little bit of a break and went to the University of Cambridge, which is where I met her, where we worked together on making an imaging system which would collect different types of imaging data for ex vivo tissues. And so that would include things like spatial frequency domain imaging, polarization imaging, as well as hyperspectral imaging. But after that brief detour, she went back to UCL on this research fellowship from the Royal Academy of Engineering, where she's now starting up her research program to advance her investigation into the cornea and the biomechanics. So I've already gotten a little bit of a preview of the talk today, but I think you're in for a treat. It's going to be great. Learn a little bit of physiology as well as optics and all sorts of things. And so with that, I'll leave it over to Abby, and enjoy, everyone.
Focused on imaging corneal biomechanics and its application in improving diagnosis and treatment of corneal disease and refractive error.
Maybe just move it up a little bit.
Not loud enough.
Pretty dim. Okay.
Okay. I'll speak louder, or try to. So I'm going to give you a bit of a background, a personal background, and then talk about some of the corneal structure and biomechanics, and then about my specific project and why I've chosen it, and what my aims are, and then I'll talk about the research I've done to date and some of the interesting results we've got from that and why that's led me to want to use some other methods, which is what I'm over here trying to explore. So as Travis said, we met at Cambridge, but before that I did my degree at Loughborough, where I did mechanical engineering for 4 years. I then went on to do a PhD at Loughborough, where my research was focused on designing a speckle interferometer to measure corneal biomechanics. So originally I actually started with teeth. I was going to look at teeth and dental restoratives because my dad was a dentist. But then I met John Marshall, who is that chap up there, and he invented the first excimer laser procedure for doing refractive correction in eyes. And we got to talking and we thought this could be a good project together. So we started working together on that. And that had some interesting results, which I'll show you through the presentation. And then I took a break for a bit and went to Cambridge to learn about some new imaging techniques and joined the group there with Dr. Sarah Bondy here. And that's, as Travis said, where I met Travis. And I got to absorb all Travis's amazing optical knowledge. Well, I didn't absorb all of it, but I got introduced to it anyway. And then I went and did a short fellowship at Loughborough to restart my work on corneal biomechanics. And then I got offered a great position, which is this RAND research fellowship, which gives me sort of 5 years to really focus on research and build my own research group and push forward my own ideas. And I've taken that to University College London, which is where I'm based now. So onto the cornea. So the cornea is a really interesting part of the body. I'm sure you all know it's the clear bit at the front of your eye. And the cornea itself has a really complex structure, which is, it has a very deliberate complex structure, both to give it transparency and specific biomechanical properties which allow it to have a shape which focuses light onto the retina. So the cornea is made of 5 main layers. On the outside here, you have the epithelium, which is a thin layer of skin cells. This doesn't really contribute to its biomechanical properties. Under this, you have the Bowman's layer. So this layer is like a really meshed layer of collagen. It's really tough and resistant to changes in hydration. And then under this, you have the stroma, which makes up the bulk of the cornea. So the stroma has quite a graded structure. Towards the top of the stroma, it's really interwoven collagen in random directions, and this really interlaces with the Bowman's layer. As you move further down the stroma, the collagen tends to go into a more preferential alignment along two meridians, so your superior, inferior, and nasal temporal, and that's to do with supporting the movements of the extraocular muscles. And that has some implications for the biomechanics, which we'll see later on. Under that, you have the Deschamais membrane, which is sort of this membrane that no one really knows much about still. And then under that, you have the endothelium, which is a layer of cells at the bottom of the cornea, and that controls the hydration properties. So also across the cornea, the structure of the collagen is very different, and the reasons this is important, they'll become obvious later in the talk. Round the edge of the cornea especially, you have this circumferential alignment of collagen. So where the clear part of your eye meets the white part, which is the sclera, you have this circumferential arrangement of collagen, and also a high concentration of elastic fibers. You also have branching collagen fibers which run from the edge all the way through the cornea to the center. And again, you'll see that this is quite important later on. So the cornea exhibits quite complex elastic properties. It's a viscoelastic material, so it has a different stiffness at different strain rates and strains. So in strains way above those that you'll experience physiologically, the behavior will be determined by the strength of the collagen. So if you really pull the cornea, what you'll be measuring is the tensile strength of the collagen. But as you go into the physiological range, the other factors become much more dominant. So the physiological range would probably be considered anywhere between sort of 12 millimeters of mercury to, say, around 60 millimeters of mercury, where, say, people with glaucoma might go up to these levels, or if you're rubbing your eyes or pressing on your eyes for any extended period of time, the pressures might go up to these levels. But the main physiological range is this range between 12 millimeters of mercury and sort of 22 millimeters of mercury, and this is the range we're really interested in, and the properties in this range. So in this range, what we think the behavior of the cornea and the movement of the cornea isn't dominated essentially by the strength of the collagen. It's both the elastic network and some interesting specific features of the collagen which dominate the response to loading. So this image here is of the synchrotron in Oxford, diamond light source, and they've done here, with a group we work with in Cardiff, has done some wide-angle X-ray scattering and small-angle X-ray scattering, and they found that at these low pressures, that collagen crimp plays a big part in the elastic response of the cornea, and also like these tropocollagen springs, which they found, and it's the unwinding and the stretching of these springs which dominates this behavior. And this is all quite new stuff that's really important in corneal research. So why corneal biomechanics? So there's quite a widespread application of this knowledge, and there's a really high demand in the clinic at the moment to understand more about corneal biomechanics. So there's several people who have a disease which has some genetic components, but also there's some people who get it and we don't really know why, and that's keratoconus. So with keratoconus, there's an abnormal stiffness of the cornea, which causes, usually in a localized area, which causes the cornea to gradually steepen in topography. So you get this cone, essentially, form on the cornea in advanced cases. Some people like to refer to it as nipple eye because your eye looks like a nipple. And yeah, it's quite a debilitating disease. If it's not caught early, often people go on to needing very complex vision correction, so hard contact lenses, complex glasses, and in bad cases they'll require a corneal transplant. So ideally we want to prevent that. In addition to this, about 1 in 20 people currently have biomechanical abnormality which we can't detect in the clinic. So this isn't necessarily something that's going to bother them in everyday life. Maybe it contributes to their prescription and the specific care they need for their eyes. But it is something, if they decide to go on to have laser eye surgery with it, which is an elective procedure, that can put them at high risk of developing complications such as post-LASIK ectasia, which can then result in them either going, having very poor vision or going blind, even to the point of needing a corneal transplant. And if we could detect these, it would be completely, preventable. All this, like laser eye surgery, isn't a surgery that anyone needs. It's an elective surgery, so these are very preventable. But better knowledge of corneal biomechanics has the potential to affect almost everyone who wears glasses, and almost everyone really, as our vision deteriorates with age and we develop presbyopia. In addition to this, it's really important in surgical procedures. So a lot of surgical procedures, refractive surgery especially, is focused on the cornea. This one up here, where there's a flap, that's LASIK, so that's quite a large change to corneal biomechanics during that procedure. But also cataract surgeries go in through the cornea, and refractive surgery is the most common elective surgery, and cataract surgery is the most common surgery performed worldwide. So this has a huge implication for tens of millions of people every year. So as I've listed down here, if we had greater knowledge of biomechanics and ways of imaging biomechanics, it would mean earlier diagnosis of disease, safer procedures, patient customized treatments, and treatments will be available to a wider population, and we can prevent surgical complications, which results in lots of savings for the individual. They don't have to wear glasses, they don't have to pay for those changes over a lifetime, and also in the health service. So I don't know about the US health service, but in the UK it would save the UK health service lots of money, which in turn saves the taxpayer lots of money, which is very important in the UK. So a brief discussion of some current ways we screen for biomechanics in the clinic. So this is the main way currently we assess someone's corneal biomechanics in the clinic. I'm sure you've all had this test where you sit in a seat, you stare at something, and they puff some air into your eye. So what they're doing here is they're recording the response of your cornea as it goes in and then back out again, and they're using that to estimate your risk of keratoconus or other diseases associated with abnormal biomechanics. So they'll do this before you need surgery. It's in general just a normal part of a routine eye screening. The problem with this method is we're shooting a puff of air at the center of the cornea, and we're recording the deformation along one strip. And we know that diseases associated with biomechanical abnormality, they usually localize, especially at a really early stage. So from this information, it's actually really hard to pick it up. Even when we're using this information in combination with like topography scans, tomography, even then we have advanced algorithms and the specificity is low, and the sensitivity even isn't where we need it to be. We're not picking up those early stage cases. We will pick up outright keratoconus, but by then we can't have optimum treatments because we've seen it too late. And in the lab, the current gold standard for measuring biomechanics in the lab, and what you'll see in most papers, is actually they use tensile testing, or what they call strip extensometry. So they take a slice of the cornea and they cut it away, usually either down the superior inferior or the nasal temporal, and they subject it to testing in a tensile test machine. So this obviously has loads of problems. The cornea is curved, so putting it in a tensile test machine is not ideal to begin with. People have had variations where they'll stretch it in different ways, but also, as I showed you on those first few slides with the corneal structure, if we remove the cornea from that globe, we're severing so many fibers that are interacting with each other that what we're measuring here is kind of redundant at that point. And also, the pressures and strains that are being used are way outside the physiological range. So my research focus is kind of addressing this whole pathway through care. So currently, like a person will go to their optometrist or the optician or their ophthalmologist and have a routine eye screening. Maybe they've got some vision changes, maybe they're just having a routine eye screening. And currently they'll take these sort of measures, usually with the air puff tonometry. So they'll pick up, you know, a really abnormal cornea, but anything else is sort of, you know, just put in a pile and come back later if you've got any visual changes. Maybe they'll note how your prescriptions are changing over time, and that'll help them detect things further down the line. But it's all a bit too late. So if they pick up that you've got keratoconus now, you'll have standard treatment, which is either like a whole crosslinking, which I'll discuss in more detail later, or if they pick it up late, you'll go for more advanced treatments like corneal transplant. In these cases with these treatments, afterwards, because the visual outcomes aren't optimized, it means that you'll need to have glasses or contact lenses, which is again an increased cost to the NHS or the person as an individual. And another problem with this pathway is anyone that's determined normal and actually may have subclinical abnormalities, they may go on to go, okay, I want laser eye surgery, and then end up with issues as a result of this. And even if they don't necessarily end up with issues, after you usually have laser eye surgery, after 10, 15 years, your eyes will start to deteriorate again, and we can't do a follow-up treatment or anything like that. You know, because you've had such an invasive treatment, it's not possible to change after that time. So if we could have a way of screening for biomechanics in the clinic where we can image you know, and diagnose spatially and specifically any areas of abnormality, that would have a huge impact on this care. So you could pick up normal and subclinical keratoconus. You'll be able to apply targeted treatments with optimized visual outcomes, where you wouldn't need follow-up treatments. And patients that are normal, because we would have these laboratory studies where we'd be investigating ways to improve procedures, make them safer, improve the stability of outcomes, it means that they could have, you know, confidence that they were going for procedures which are very low risk, and the outcomes are likely to last them for their lifetime. So yeah, the main focus of my research is clinical device development, and also to use laboratory studies to quantify important biomechanical properties that are relevant to the clinician. So yeah, this is a summary of basically what I said there, that we want to carry out these studies to find properties that are going to be important and translatable to clinicians. So not necessarily defining a Young's modulus or defining these. It'd be good to image a cornea and see what would be important in diagnosis. And then to use this data to inform procedures and potentially develop new procedures as well. So I'm going to discuss my research to date. So my research so far is focused on using speckle interferometry to examine corneal biomechanics before and after these specific interventions, which have been crosslinking, refractive surgery, and corneal implants. So I'll give you a brief overview of speckle interferometry, but I'm sure most of you know about it already. So in speckle interferometry, we use coherent laser light and we shine it at a surface. This surface will be optically rough, and the light scattered from that surface we interfere with a reference beam, and it gives this a rise to this speckle pattern. Essentially, it doesn't come out very well on a camera here, and that speckle pattern contains information about the position of that object surface at the time. So when the light scatters off the surface, it'll intercept the reference beam at a specific point in the wave, and that gives rise to the speckle. So when that surface moves and the reference beam stays at the same position, we can take a second image and subtract that from the first image, which will give rise to these interference fringes here. So say that's a membrane there, and we increase the pressure, we'd see the formation of these interference fringes, and these can be thought of as like contours of equal displacement as such. And if we know the configuration that we've used, we can then work out from these fringes what the specific displacement is in a certain direction. So this is basically a summary of that. So we image the cornea at baseline pressure, so what would be a normal IOP, which in the human eye is about 16.5 millimeters of mercury. And then after we've imaged the eye at that pressure, we increase the pressure in the chamber. We then image the eye again. We also phase step the reference beam, and this is so we can unwrap the fringes later on down the line. And then we record the fringes at that final pressure. We generate a wrapped phase map, which will look something like this. These contours can then be unwrapped here, so we're just removing the 2π discontinuities here to create a smooth phase change plot. And then if we know the specific setup, we can then calculate the displacement from this. So an alternative to displacement interferometry is shearing interferometry. Now, shearing interferometry can be really useful in environments where there's a lot of vibration, a lot of noise, because you're not using a reference beam that's separated from the object beam. So you use the object as its own reference, which means in a clinical environment or any noisy environment, this can be more robust to noise. So in this case, we use lateral shearing interferometry, which means we laterally shift the two images. And we do this by taking the signal from the object surface and splitting it in half and reflecting one half off a flat mirror and one half off a tilted mirror. And this gives us, essentially offsets the two images, and you interfere one point on the image surface with a point essentially laterally displaced. So it's comparing the displacement of those 2 points. So you do the same procedure where you take a reference image and then you take an image when it's finished loading, and from this you get essentially a map of the gradient of displacement, and then you can integrate this with respect to the direction which you've put the shear on to get the displacement. So why speckle interferometry? Because it's real time, so you can see those fringes forming, which is really interesting on the eye, because if there's areas of damage when you watch the fringe formation, it's quite easy to pick out those areas because you're comparing the surface relative to other points on the surface. It's non-destructive, so you can look at the same eyeball before and after an intervention, which is really important, obviously, with biological tissues because there's so much variance between specimens. It's got a really high sensitivity to displacements on the scale of nanometers, really high spatial resolutions. And yeah, viewing the displacement, and especially the gradient of displacement across the surface, is a really effective way to pick out areas of abnormality, because you are literally comparing it to neighboring points on a surface. You're not using reference values of, like say, a Young's modulus or other values where across a population there might be a huge variance. It's allowing you to assess those corneas as individual corneas. There are also many disadvantages to interferometry, which I will discuss later. So this is the device that I created during my PhD. It's actually a combined displacement interferometer and shearing interferometer. We did this because we weren't aware how well the displacement interferometer would work in a clinic, and we also wanted to look at sort of the differences in terms we were getting in the image. Maybe it'd be easier to pick out abnormalities with the shearing results. Maybe they'd be more obvious and intuitive from the displacement results. So it's kind of just giving us the opportunity to do both. So with the displacement interferometer, it just meant we had this shutter open, and this we were phase stepping using a piezo. So this piezo was turned on, and then with the shearing interferometer, we just switched it around, so the other piezo was turned on. So it was a really quick switch between the two systems, and also we could control the amount of shear and the sensitivity of the shearing interferometer by just using these two screws, which would change the shift of the images in direction and magnitude. So this is a uniform membrane, just to make things simpler. So for displacement, we'd see these sort of rings, and then the shearing, you'd see the gradient of that. And for the specific setup we were using, we were illuminating normal to the sample and imaging normal, so the sensitivity was in the axial direction. So each fringe we were seeing was equivalent to half the wavelength of the laser which we were using, which was a green laser at 532. So each of these fringes was essentially a displacement of 0.2-ish microns. So with the eye, we saw quite a different distribution of fringes to what we would see with a uniform membrane. There was a really high concentration of fringes around the edge in the displacement map and in the shearing map. And for ages I thought, well, I'm just doing something wrong, because I just went through hundreds and hundreds of eyeballs, and I was like, why is it always near the edge? Why am I seeing this? How am I loading it wrong, or I'm clamping it wrong, or whatever? But after a while I was like, oh no, actually this is just how it deforms. So this really high concentration of fringes at the edge, this is because this is where most of the displacement is happening in response to pressure changes. And this is especially obvious on the shearing map. So there's a really high gradient of displacement in that area and almost nothing across the central area. And this is because the central area isn't really changing in curvature in response to pressure changes. And this makes a lot of sense, because if your eye was constantly changing in curvature every time your heart beats or every time you blink, then your brain's going to have to do a huge compensation for that. But if for example, it's just a movement forward, then your brain's only having to compensate for that movement. So what we found is this circumferential band of collagen at the limbus was playing a huge part in how the cornea was deforming in response to these physiological pressure changes. And this deformation was quite elastic, because it was mostly in these elastic fibers. So this was quite an interesting finding at the time. And kind of has quite a few implications when thinking about correcting people's vision. So as I said, we're only measuring the axial movement here. So we thought, okay, maybe the cornea is like bulging out laterally. So we did some more investigations where we didn't use interferometry to look at the lateral deformation, because it was actually really hard with the topography of the tissue and the fact you had to use an angled beam. And the beam, in terms of sensitivity, the more you angle it, the more sensitivity you get with regards to movement in this plane. So we would have had to use quite a high angle, and that just doesn't work on a curved tissue. So we used just digital image correlation to look at the central band, and we found actually the cornea wasn't moving a great deal in those directions. It was kind of moving like a bellows effect from the limbus. And yeah, this was useful because it made interferometry easier to use. We didn't have to constantly do this. But yeah, it was an interesting finding, definitely. So moving on to corneal crosslinking. So I don't know how many people are familiar with crosslinking, but in the eye, we can soak a cornea in riboflavin, which is a photosensitizer. Then we can use UV light to basically accelerate the crosslinking procedure that occurs normally with age. And this causes stiffening in the cornea. We don't really know why. We don't know how the crosslinks are forming, what the crosslinks are forming in between yet with confidence. So that's still an active area of research, but we do know that it increases the stiffness of the cornea. So this is used currently to treat keratoconus. They crosslink the whole cornea, and that stops progression of the topographic deterioration with the disease. But what is of real interest is, could we use this treatment in a targeted way, where we can change the stiffness of the cornea in specific areas to essentially provide a bladeless refractive correction? So if we change the stiffness in the center, for example, can we then induce a flattening of the cornea just by changing this stiffness relative to the surrounding stiffness? This is of huge commercial interest, obviously, because not only would this improve the treatment of keratoconus and optimize visual outcomes of treatments of keratoconus, but if this could be performed as a refractive correction, it opens up the market from several thousands of people with keratoconus to millions of people every year who might want refractive correction. So we did some experiments where we measured corneas before and after crosslinking. So this example is a central crosslinking, and what we were expecting to see is sort of in this image that we crosslink this central area, and as a result the cornea is flattened due to the different way it deforms to the pressure variation. So this is a displacement map before the crosslinking, and then this is a particular one after we did that central crosslinking. So we did see kind of what we expected to see in this case, where we got a reduction of displacement in the central regions and a compensatory increase in displacement in the regions outside of this. So these red lines are afterwards and the blue lines were the profile before. This is just taken through a section here. So that kind of was promising. It showed what we wanted to see. Then we went on to do like a donut region around the outside. So this sort of case would be to treat long-sightedness. So by cross-linking around the outside, what we'd hope to see would be a steepening in the central cornea. So we saw quite a large decrease in the displacement in response to the same pressure change after treatment. And the decrease was definitely less in the central region compared to other regions, but it was quite slight. This probably wouldn't introduce enough of a change to treat hyperopia, which is already something that's hard to treat. And actually, this kind of feeds into what I was saying before, that central curvature of the cornea is so good at staying, the same at all times, that it's actually quite difficult to force it to change. And then we did a central strip. So this would be for something like astigmatism, where the power in one axis is greater than the other. So as you can see, after cross-linking, it was significantly lower displacement in response to a pressure change. Along this central strip, the displacement was very flat, and then you got this, similar to when we did the central cross-linking, this valley sort of flattening in the corresponding axis. So it kind of, again, gave us exactly what we expected to see. Then after playing around with hundreds and hundreds of eyeballs in the lab for several years, I eventually got used to what a normal fringe distribution would look like on like a pig's cornea, for example. So after this time, I thought, okay, well, say I see an odd fringe distribution one day, I'm going to try and treat it in a specific area where I'm seeing those odd formation of fringes. So I found this eye, and this eye was showing really high displacement on one side relative to the other. So I thought, okay, I'm going to cross-link this cornea. I'm going to cross-link half the cornea to see if that works. So this, by the way, wasn't a mask generation, an optimization algorithm. It was my own head at that time, but this would be the ideal scenario, right? If we could apply this treatment, we would have an algorithm. And we did see kind of exactly what I wanted to see. So we flattened the response across this area. These points still remain pretty high, but that was also reassuring because the beam we were using only had a 9mm coverage zone. And because this was a pig's cornea, they were kind of outside of that zone, so they didn't change as much as the surrounding tissue. So yeah, I was really pleased with those sort of results. And from that, this is like a really interesting area of research where we feel we can take it forward with more imaging and more data, is to produce these algorithms which will enable people to apply these treatments in a very precise way. Because within cross-linking in itself as well, there's so many variables like oxygen concentration which can affect it, how much power is used, whether we gradient out the power. There's so many areas where there's room for optimization, but at the moment we can't really explore them because we don't have any information. So surgeons are doing these optimized treatments on patients, but they're guessing currently. And if we could provide the data which would say if you apply these powers, we expect to get these refractive outcomes, that would be like really important in the industry. So corneal implants. For like really advanced keratoconus cases like this one, where there's a really significant bulging of the eye, and I doubt this person can see very well at all, usually those kind of cases require corneal transplant. So corneal transplants have lots of issues, obviously host immune rejection. they're quite difficult procedures, but a really big issue, especially in the UK, is that we have a massive shortage of donor corneas. So about 1 in 70 people is able to get tissue and be treated. So we've been working with a company in Germany to test their implants, which they're developing. So they're using pigs' corneas, and they are creating these thin lenticules. So they take a punch from the center of a pig's cornea, where the Bowman's layer and the top part of the stroma is. They then decellularize these, they wash them, they compress them, and they cross-link them to create these like stiff and very thin implants. And they insert these into the cornea. It's a much less invasive procedure. They make a small incision in the cornea, and they also cut out space for the lenticules. So this is an outpatient procedure. It's not an inpatient procedure like corneal transplant. So they got us to test some of their lenticules, which they developed, to see how much they'd stiffened by, and some other features. So we tested some of their lenticules. These were just lenticules before any processing, so these haven't been decellularized or anything like that. And then these were after the processing they applied. So we found that they did increase significantly in stiffness by about 120%. But they also, the variability by which they increased was quite high. And in general, people's responses to cross-linking and other treatments is very variable depending on the person, depending on their genetics. So this could be quite a problem in terms of using these implants in people. If they go wrong, do we know that the implant was a good implant? Because there's significant variation between the implants. So to use this in the production line could be really useful. Corneal implants in general have been associated with quite a number of side effects. So you get an increased glaucoma risk, usually severe astigmatism. Sometimes they can correct astigmatism though, so it depends. But you also get corneal melt around the prosthetic in a number of cases, and these are generally thought to be due to bioincompatibility. So interestingly, with these implants, obviously they're making them stiffer and stiffer and thinner in the sort of hope they'll treat keratoconus, which is this biomechanical weakness of the cornea. But if we're making them too stiff, is it going to actually cause more problems than it solves? And also, can we then, say we put a stiff implant in, could we then do a treatment like cross-linking around the implant and grade out that cross-linking to make them less likely to cause issues with incompatibility between the neighboring tissues? And ideally, we need to be able to image how the implant is interacting with those tissues under pressure. And this is something that obviously isn't possible with interferometry because we can only measure the surface. We need techniques where we're able to measure further down. So as I said, not possible with interferometry. My other work's been run with refractive surgery. So as I said, it's the most common surgery performed every year. There's several different types of refractive surgery available now. This original procedure, which was John Marshall's sort of procedure, which is PRK. In this procedure, you just scrape away the epithelium of the cornea and you ablate the surface underneath. In LASIK, which is the most popular procedure and probably the most common one performed now, they cut a flap in the cornea, they lift it up, they ablate the layers underneath, and they reposition the flap, and then that heals as such. And then the newer technique is this SMILE technique. So this is a keyhole version of LASIK, essentially. So in this, what they're doing is they're using a laser to cut a lenticule out of the cornea at a specific depth. They then make a small incision in the surface of the cornea, and they pull this lenticule out. Now they're saying this biomechanically better because you're not creating this whole flap, you're not severing all these fibers. There's actually no evidence, and there's been a few cases now of like ectasias forming after SMILE surgery. This has very low risk of ectasia. 96% of all ectasias have come from LASIK. So it's kind of interesting that no one's really investigating this. So I've been working with Professor Reinstein at the London Vision Clinic, and we were looking at deformation of the corneas before and after surgery. So this one in particular is PRK. So this was before surgery, the displacement, and then after the PRK surgery, the same displacement. So it increased in displacement in response to the same pressure change, which we'd expect if we burn away some tissue from the top of the cornea. Then we looked at LASIK. So we did before, and then after. Now, interestingly, after it looked like the displacement was less. And this is where interferometry is just totally limited, because in LASIK you're doing a procedure which is further down in the cornea, but we're only looking at the surface. And obviously the surface is now fairly detached from the biomechanics of the rest of the system. So we saw these high displacements right around the edge of the incision, but then across the incision it looked like the top surface wasn't really displacing much at all. But that's probably not the full story. We're just not seeing what's happening underneath, and so that's a big problem. Then we looked at SMILE. So this was the before image, and then after the lenticule had been scraped out, there was a big increase in displacement, kind of uniformly across the sample. But as you'll see in a minute, this isn't really the full story. And this is at SMILE again, at a different depth. Again, there was an increase in displacement after the surgery, especially in that central bit. But then these were some more SMILE results. So in this case, there was a decrease in displacement, especially in the central area where the lenticule had been removed. Here, there was a decrease in displacement, but a weird hotspot in the central area. And this just shows the limitations when it comes to interferometry when investigating these procedures. We've essentially done something through the thickness of the cornea, and then we're just measuring the surface. So yeah, interferometry might be good when looking at the surface response after these treatments to the surface only, so crosslinking or PRK. But then these ones where we're looking at basically damaged tissue further down in the cornea, this isn't ideal. We're also only measuring in one plane. Maybe after SMILE or other surgeries, the deformation's going more laterally. We don't know. So this is why I think the best way to look at these procedures is with a multimodal imaging approach and 3D imaging, and also complementary techniques to look at other processes. So yeah, so with multimodal imaging, an example here would be to use interferometry in combination with something like OCT. So OCT is really good at looking through the cornea. Obviously, it's already an established technique in the clinic. The problem with using it to look at biomechanics is that it requires scanning, so it takes a lot of time, and this can cause problems with motion artifacts, also corneal hydration when you're doing it in a laboratory. So the idea would be to use interferometry to get this whole surface map in high resolution, really high displacement resolution, and then to target areas of interest with OCT to look at the through thickness strain using these techniques. So OCT with digital volume correlation to look at the strain through the thickness. Another way we're looking at things like the mechanisms behind crosslinking is to do crosslinking at the synchrotron and to look at the scattering to see if it changes the way in which these collagen fibers are behaving on a real micro scale, looking at basically the biomechanical mechanisms and how they change. Then using techniques such as like polarimetry, where we can look at the collagen and the birefringence and how that may change after surgical procedures or after crosslinking procedures, and whether we can gain information from that. And then just other complementary techniques. So we can use it two-photon microscopy to look at the amount of crosslinking that's taking place. So if you give two people the same treatment, one person's cornea might stiffen significantly where the other person's might not. If we could measure the amount of crosslinking that's actually occurred, that would really help us quantify what's going on. Then SHG imaging or TEM imaging to look at the structure, and high frequency ultrasound could be give us a similar information to this, some through thickness images. So the other part of my work is on building clinical imaging devices. So the idea would be to have a scan which would be something that would become part of every routine eye exam. It would take less than a minute, and we could spatially map the movement of someone's cornea in response to a pulse or a physiological pressure change. And then we could screen for patients that are high risk for surgery, but we could also then apply these customized treatments that we're trying to build algorithms for. So that's the plan. There's obviously a lot of research going on in this space because there's huge commercial potential for any device in this area. The main techniques that seem to be picking up in this area there's Brilliant microscopy. They are using this technique to essentially it's a very complicated technique because both hydration and density affect the measurement of the elastic properties of the cornea. So it's a really hard technique to apply in biological specimens. The thing that makes it really difficult to apply in a clinic is the scanning. So currently it takes 5 minutes for a 40-point scan, and you're likely to miss very small areas of localized abnormality with these techniques. Optical coherence tomography is being used in a number of different ways, usually with like a vibratory excitation, and then we're doing scans, but often they involve contact with the eye, which a lot of people don't like in the clinic. But this is an interesting area of research. The problem is no one's really taking full scans with these things. We'll maybe do a line or a small area, but it's too time consuming. If you're a doctor, you haven't got 10 minutes to scan everyone's eye. And then similar with high frequency ultrasound, they're trying similar techniques to optical coherence tomography to see if they can pick up these early stage changes. But yeah, if you look at the size of a clinic, the main requisite for an instrument is it has to be able to fit in a clinic. I like this example because it's on a huge optics table, and I'd really like to move something like that into an ophthalmic clinic, but I don't think anyone would want it. Yeah, so they have to be no contact would be ideal. You know, you don't want people having to sit and bite on a dental bite for 5 minutes. You need to measure the whole cornea, ideally in one image, and to prevent any motion artifacts. And yeah, the time is critical. 30 seconds to a minute scan is really what anyone has time for in the clinic. Anyway, that is the end of the talk. If you have any questions, then let me know. Yes?
You mentioned a technique where you inject something in the cornea to strengthen the crosslinking.
Yeah.
What was the material that you inject, and also is this something that lasts for a long time, or the body reproduces the cornea and that crosslinking effect goes away?
So you don't inject the cornea with anything, you just soak. So you'd soak the cornea for 10 minutes with a solution of riboflavin. So the patient would be lying down and you would just put it on top of the eye, and that riboflavin would just infiltrate into the stroma, and then you can shine UV light onto it. So it's a very minimally invasive procedure. There's no cutting of the cornea or any injections involved. There's been follow-ups for like 20, I think up to 20 years now, and the cross-linking effects do last. The stiffness increase does last. It's also something where there is potential for follow-up treatments. It depends. The collagen only will have so many cross-linking sites, so there'll be a point where you cross-link it more and nothing would happen. Nothing would increase in stiffness. But say you did a conservative treatment where you increase the stiffness a small amount, there's potential that you could then do a further treatment later down the line. But it's still a very... knowing how cross-linking would affect a normal cornea in comparison to a cornea with keratoconus hasn't really been researched well, because all the treatments so far have been carried out on keratoconic corneas where they have significantly stiffened the cornea and stopped the progression of any topographic changes. But because they haven't been used for refractive correction, we can't tell you if the refractive properties of the individual then deteriorate over time. As far as has been reported in the literature, they don't continue after cross-linking to deteriorate in any way.
So for coverage of the cornea, typically the big problem is you got this very convex surface, and so
Yeah.
you need a very fast, large optical system to cover it. But because you're using scatter interferometry, are you able to get all the way out to the limbus with your...
Yeah, so speckle interferometry is really good. So your limitation is just your beam size.
Mm-hmm.
So we put corneas in the if I find the picture of the chamber. So we created like a fake anterior chamber, this sort of area here. So this area across is a 25 millimeter diameter, so much bigger than the cornea. We're clamping as far out in sclera as we can. and then we can illuminate this whole area and get the deformation of this area in one image, which is really useful. But you're just limited by your beam size and your optics. That's it.
And then if you went to shorter wavelengths, could you just get scattered light from internal to the cornea to get information about biomechanics internally?
No, so currently what we do is we coat the corneas because we want to we don't want to get a mix. If you got a mixed signal back, it'd be very hard to position it so you were getting a very specific signal from an area in the cornea. And also, you know, a lot of light is transmitted all the way through the cornea. It doesn't scatter off, so you get a lot of noise if you try to do that without any sort of coating. That is also a reason that I don't think speckle interferometry itself is going to be the technique that moves forward to being an in vivo technique, because it's far too sensitive. If a person's eye moves like half a speckle, then you know the whole thing there'll be far too much noise in the image to get any information from it. So it's not really a technique that's applicable in vivo. We are using a different method for that, but it's just a useful technique to look at the surface deformation outside the clinic because it's very quick and very simple. Yeah.
On that particular slide, I'm kind of curious, how did you get the cornea itself secured in your special chamber that you're using there?
Okay, so those chambers are actually, you can buy a commercial anterior chamber, and they're used for the preparation of like donor tissue before it's transplanted into an eye. So what they have is there's like a water chamber underneath. So under the cornea there's basically a snout where water will come out, and then over that we 3D printed a cap with the right aperture for the chamber. We just push that cap on, and you can see this that collar there. That's a threaded collar, and that then exerts a force onto the cap, so it just pushes it and holds the cornea in place.
So I've got one last question.
Yeah.
So I think, what of the modalities that you talked about do you think would be most likely to make it into a clinical scenario, since you just kind of talked about why speckle interferometry is probably not the best case scenario for that?
So we're using a range of different techniques. We're exploring a range, but we're focusing on techniques based around like reflectometry and deflectometry to look at clinical imaging. But like I say, other groups are focused on like OCE is what they call it, or this high frequency ultrasound, but they're held back at the moment by scanning and the fact that if you're scanning in vivo and you're then having to like push all your data together from different scans, it's actually really hard to do. So yeah, secret work, Travis, that though.
Excellent. Any other questions? You have one more?
All right, so you just mentioned using deflectometry to kind of measure the properties of the cornea. Deflectometry tends to be pretty difficult when using convex surfaces. So I guess what type of geometry would you use to overcome that?
Yeah, there's a few things we've been playing around with that I'm kind of reluctant to discuss at the moment, mainly because it's in the like very early stages. It was essentially I was playing around in my kitchen during lockdown with projectors and things like that. So it also just might be completely useless.
I feel like that's often the case with early stage ideas.
Yeah.
Excellent. Yeah. Well, let's give another round of applause for the speaker. And thanks everyone for coming this afternoon.